Hello, my name is Dr. George Kirov. I'm a psychiatrist and I work for Cardiff University, where I do research on psychiatric genetics. So I was asked to give you a talk about bipolar affective disorder, or manic depressive illness, as it is also known. I've got a presentation which I'll share now. Yeah, it's working. So you can, if you know about depression, and I think all of us know what depression is, because I'm sure everybody has felt down at some point in their lives. So mania is more or less the opposite of depression. And strangely enough, it happens as part of the same illness. Same people who get depressed can become manic at some point in their lives. Not very often, fortunately. Now, to demonstrate to you the issues around manic depressive illness, I've picked up a very typical patient that I came across some years ago. So he was born in 1945, and at the age of 26 developed his first depressive episode. He was seen in outpatients, given amitriptyline, which is an old antidepressant. We call it tricyclic antidepressants. They're depressants with many side effects, but also they're very effective. He improved and was well for a good 10 years, not on medication, probably forgot about his depression, and then had a second episode when he developed some signs of somatic anxiety, like feeling that his heart is beating faster, having headaches, shaking, did not want to do anything, and did not want to live. The doctors felt his condition was more serious and hospitalized him. He improved again, but 2 years later he had a similar presentation, again requiring hospitalization. This time he started lithium maintenance treatment, and I'll tell you briefly about lithium later on, but generally it's a very good drug for providing prophylaxis against the recurrence of these disorders. It kept him well for 7 years until he got depressed again, and he was restless and he was frightened, and this time he started developing some psychotic features. He had delusions that he was being investigated for past crimes and that he'll go to jail. This was all in his imagination. He didn't have any past crimes. He did not respond to antidepressants, and this time he required electroconvulsive treatment, or ECT. He had 10 sessions and he improved. And another episode, again, serious episode, requiring another course of ECT. You can see up to this point, and this is now more than 20 years of development of his mental illness, he had only episodes of depression. Until 1995, when he presented in a very different condition. He was moving all the time, he was full of initiatives, he was spending money indiscriminately. He claimed that he was in touch with the government, that he had a lot of money. He had 5 companies. Of course, all this was not true. He was arrogant and rude. He was sleeping less. He refused medication. In fact, he felt better than at any other time in his life. his behavior was too disruptive, so he needed hospitalization. On the hospital, he was very talkative. He was trying to help staff with everything. He was interfering in every activity, and he had lively mimic gestures. He felt happy, overactive, and he refused to accept that he was ill, so he was treated against his will. And he was actually treated again with lithium and antipsychotics this time. And he stayed well on lithium for another 10 years when he had another episode of mania. So this is quite a typical picture of manic depressive illness. Acute episodes, followed by full remissions and various duration of these remissions. And most patients require long-term medication to reduce the severity or the frequency of these episodes. So what about symptoms? So here I have divided the symptoms into three main groups. Those symptoms that have to do with the mood of the patient, with the motor activity, or with the thinking. And all these three areas are speeded up or elevated. So the mood goes high, typically elevated, happy, like the patient I showed you. But sometimes they can become irritable. So they can be very easily annoyed, and it's not a good idea to argue with a manic patient because they can switch very easily from being happy to being irritable or even aggressive. They can be inappropriate. You'll recognize the manic patients. If you walk into a psychiatric ward, the manic patient will greet you first and will tell you something about you, maybe something you don't want to hear about yourself, because they have no inhibitions. Their activity is increased. Typically, they're very productive. They have much more energy than us. They require less sleep, and when they wake up, they're full of energy. So a depressed patient, if they wake up, they feel dreadful. Manic patient might wake up at 2 a.m. and say, great, I've got so much time now, I can do these wonderful things. Let's ring my boss and tell him about my great plans. So they can actually be productive and get a promotion at work and be very interesting in a company if the illness is mild. When it gets more severe, things go out of control. Their concentration drops, so they cannot finish what they started. So they have many ideas, but they don't finish any of them. They become overfamiliar, which can be very inappropriate. They get increased interest in sex. And it's not that unusual for very decent women to start undressing on the ward. And when they recover from the manic episodes, they feel very ashamed. Recently, actually, I had a patient who did something inappropriate, sexually inappropriate on the ward when she was manic. And had been depressed after that for a number of years, refusing to have ECT, although ECT helped her before. She was worried that ECT will make her manic, so she felt so guilty and ashamed of what she did when she was manic that she refused a treatment that would help her recover from her very nasty depression. Thinking is faster. People speak faster, but also have got what is described as flight of ideas. Their thoughts jump from one topic to another, and this could be because they were distracted by something, or a word sounded like another word, so they changed the topic completely according to this other word. So it's called clang associations. Some people are able to write poetry, and if somebody on a psychiatric ward comes to you with a poem, you know what the diagnosis is. Unfortunately, when we treat them, they recover from their manic episodes, they lose the ability to write poetry. And they can develop grandiose ideas. They can do some crazy things. They can attempt things that are even physically impossible, and they can get into big trouble or injure themselves because they believe they've got great powers. They do indeed have great strength, and every psychiatric nurse knows a story about some manic old lady who was so strong that she required 4 male members of staff to restrain her. If you have talent and you're manic, you might do some great things, like you can write better. So Virginia Woolf, who had manic depressive illness and actually drowned herself at the end of her life, knew that when she was high, she was able to write better. And she said, it is in its lava that I find most of the things I write about. Hemingway definitely suffered with severe depression, for which he received an ECT course, which was not successful. He shot himself. Now, he's not really known to have been manic, but he was a very entertaining person when he was well. So maybe he had some hypomanic features. And Tennyson is the best known example of a psychotic manic depressive writer. And there was a family history of manic depression. A more recent example is Robin Williams, who was known as have been manic and also suffered severe depressive episodes, and finally he killed himself by hanging himself. Van Gogh is the best known example of a painter who had probably manic depressive illness. He certainly suffered with bouts of depression, but his psychotic episode was very unusual, and whole books have been written trying to explain what he suffered from. It was probably some form of psychotic affective disorder. He had strong psychiatric history in the family, including schizophrenia. Schumann is an example of a musician who suffered with manic depressive illness. He attempted suicide. He finally got himself admitted into an asylum and spent 2 years there and starved himself to death. Now, this graph shows his musical composition. So every number is a code for a musical piece that he wrote. And you can see that in some years he was very productive, and in these years he was actually hypomanic, and in other years he didn't write anything because he suffered with depression. He was somebody who had musical hallucinations, and even one of the themes he wrote, he actually heard it and thought that the angels sent him the tune. How do we diagnose mania? There is a rating scale which clinicians can use. It has 11 points, measuring things like elevated mood, increased motor activity, increased interest in sex, reduced need for sleep, the level of irritability, the rate and amount of speech, any evidence for language problems or thought disorder, typically the flight of ideas or even incoherence in severe cases. The thought content, so rating the presence of any grandiose ideas. The behavior, which can be disruptive or even aggressive. The appearance, which could be disheveled or overdressed, too colorful, too extravagant. And the presence or absence of insight. According to the DSM criteria, whether it's 4 or the new 5, you need 1 week duration of illness to be called bipolar, and you need impairment of functioning. So things like getting hospitalized, losing your job, getting a divorce. So this is kind of severe level of impairment, which is required to be called bipolar 1 disorder. I'll tell you what's the difference between 1 and 2 later. And you need 3 symptoms, at least 3 symptoms of these same symptoms that I think we've mentioned a few times now. So what's bipolar 1 and what's bipolar 2? Well, bipolar 1 is what I've been describing as severe episode that can be psychotic. It causes impairment of the functioning, and you need at least 1 week. For bipolar 2, it's generally a milder episode, which does not lead to severe impairment. There is also a duration criterion of 4 days, which is rather arbitrary. Let's face it, if somebody does something terribly disruptive, but gets better within a week, he's probably still suffering from bipolar 1 disorder. But there you are. The people who designed these criteria wanted to make sure that they're not used very lightly. You can have psychotic symptoms in bipolar disorder, and if they're congruent with the mood, they're called mood congruent. So things like if somebody is manic, they might have grandiose ideas. They can hear angels talking to them, giving them advice, this sort of thing. If they're depressed, they can have delusions that are congruent with a depressive mood, such as delusions of guilt or delusions that their body is not functioning in some way, called hypochondriac delusions. They can also have mood incongruent delusions. So if somebody is manic, but they feel that somebody is following them and wants to kill them, that cannot be explained by a happy mood, and we call it mood incongruent. If the mood is still highly elevated or depressed, we still call this bipolar disorder rather than schizophrenia. But you can see that there will be instances when the distinction is rather blurred, and you're wondering, is this mania or is this schizophrenia with some grandiose delusions? Bipolar disorder type 1, so the severe or psychotic type of disorder, is relatively rare. It affects about 1% of the adult population. It has a similar prevalence in different ethnic groups, and the age of onset is very variable. This is a graph showing the gender distribution, and in many different countries, and it doesn't matter in which country the study was done, it shows roughly one-to-one rate between men and women, maybe slightly more women. So you can see this line, which would be the 50-50 distribution. Maybe slightly more women have manic depressive illness. But if you see a similar graph for depression, it's a lot more women. This is a graph showing how disruptive the illness is. It uses data on disability adjusted life years worldwide. These are the number of years that people spent with disability. So, for example, how many years you suffered with a certain illness which was causing problems for you. And you can see that neuropsychiatric disorders occupy nearly a third of, well, or a quarter of all disability worldwide. And among that, the biggest chunk is actually for depression. And this is, you might wonder why depression. This is a fairly mild disorder. Well, it is usually a fairly mild disorder, but it's very common and it's chronic. And that's why it accounts for a lot of years lost to illness. Bipolar disorder accounts for about 2% of these disability adjusted life years. It's similar to schizophrenia or dementia. Now you could say dementia is a lot more nasty illness, but what happens is that you don't spend that many years with dementia. You develop it late in life, and then you have a much shorter life expectancy after you develop dementia. With bipolar disorder, you can be affected from an early age throughout the following 50 or 60 years. Now, the first episode of manic depressive illness can be manic or depressed. The time periods between subsequent episodes narrow until the illness kind of finds a pattern. The typical pattern is one episode per year, but it could be anything from very frequent episodes to extremely rare ones. The rule is a good recovery between episodes. But there are some residual symptoms, and certainly problems have accumulated during episodes. So the functioning might actually not be the same after people suffer manic episodes. So, for example, they might have a divorce. They might be sacked from work because they've done something very inappropriate or insulted their colleagues. Suicide rate is quite high, 10 to 15% lifetime risk for suicide. And their lives are shorter. Now, this is a slide from a study conducted in Australia showing the effect on life expectancy of different mental disorders. Here is, for example, schizophrenia. The dotted line shows the life expectancy in the general population. The green line, life expectancy in the disorder. So you can see a huge reduction in life expectancy in schizophrenia. Now, bipolar is not listed on its own here, but it's together with affective psychosis. So most bipolar types of illnesses would be here. And you can see that life is shorter by quite a few years. Why do they live shorter lives? Well, it's not just suicides, which do account for a proportion of it, but people with mental illnesses have increased cardiovascular disorders and cancer. It could be due to lifestyle, less exercise, reduced earning. You know that poorer people have generally shorter life expectancy, smoking as well. Effective medication, probably some of our medications increase the risk for diabetes. Now, this is to do with fecundity or the number of offspring that people with different psychiatric disorders have. So I use this slide mostly to illustrate the problem in patients with schizophrenia. So male patients with schizophrenia have hugely reduced fecundity. Here the bipolars, female and male, so it's actually not that much affected. It's only 0.8 or 20% reduction in the number of children. So they're functioning pretty well. They're able to form families and have children. What causes manic episodes? There are predisposing factors, or genetics really. There's some interesting precipitating factors. Things like sleep deprivation. It's an interesting one. When people, for some reason, sleep less because they go on holiday and drink a lot or something like this, that can provoke a manic episode. And actually, patients who have had manic depressive illness are advised not to deprive themselves of sleep because this can trigger another episode. There's some specific illicit drugs, amphetamines, also known as speed, that can cause a manic episode. Childbirth is another very specific cause. 1 in 500 births ends in a psychotic episode, and these psychotic episodes are usually of the manic depressive type, not of the schizophrenic type. And there are also some very interesting or specific organic causes, such as steroids. So people who say suffer with asthma, GP gives them steroids, and they develop a manic episode. So again, patients who have had manic depressive illness should be aware of this problem and avoid steroids. Thyrotoxicosis, overactive thyroid gland, can provoke a manic episode, and there is a very good treatment for thyroid, for hyperthyroidism. The whole gland can be resected, taken out. However, once the illness starts, it has its own course. So this doesn't stop the manic depressive illness if you remove the thyroid gland. So generally an interplay of genetic and environmental factors, but which ones are more important? Well, we can answer this by looking at the so-called heritability, or the contribution of genetic factors to the etiology of illness. And we can see that bipolar disorder genes account probably for 80% of the risk, which is as high as for schizophrenia, almost as high as for autism. The genetic contribution for the common psychiatric disorders like anxiety, panic, and depression is much lower. So manic depressive illness is a highly genetic type of disorder. Now, is it an illness on its own? What is the connection with the psychiatric disorders? It's probably very high. So this study from Sweden shows the connection between bipolar affective disorder and schizophrenia. So let's take, well, what I've done is they've tested the whole population of Sweden, because everybody in Sweden has their medical records on a central computer, and they're family relationships also on a central computer, and people in this country are happy for these data to be made available to researchers. So the whole of Sweden, more than 2 million families, and this is what the data showed. If you are bipolar, what is the risk in your siblings for being bipolar? And it's about 8%, but about 4% of their siblings had picked up a diagnosis of schizophrenia during their lifetime. And the opposite happened with people who were diagnosed with schizophrenia. If they looked at the siblings, okay, 9% of them had schizophrenia, but nearly 4% had a diagnosis of bipolar disorder. So there is something common between these disorders, at least the genes that contribute to them are a bit non-specific. These are family studies. What about adoption studies? So you're controlling for the influence of the environment. Why do you need to do that? Well, maybe because if your parent is bipolar or schizophrenic, then your upbringing is suffering in some way, and you're more likely to develop the illness because of the upbringing rather than because of your genes. So you need to perform adoption studies as well in order to find out whether the disorder is genetic. So in adoption studies, when the child is taken away from their biological parents and brought up in a family where there was no bipolar disorder, is there increased risk? Well, there is an increased risk according to adoption studies. So what mattered is whether the biological parents had, the illness, if they studied children who were adopted away and developed bipolar illness, and they looked at their adoptive parents and their biological parents, the rate of manic depression in the biological parents was actually higher than in the adoptive parents. Now, other interesting studies looking at whether the disorder is genetic is what happens to monozygotic twins that are discordant for illness. So if one monozygotic twin is bipolar and the other one is unaffected, this actually happens in about 50% of monozygotic twins. So if one twin is ill, the risk for the other twin to be ill is only 50% rather than 100%, which already tells you it's not completely genetic condition. But let's see here. So if it was to do with the upbringing, then you expect that the children of the twin who is ill will have a higher risk of being ill than the children of the twin who is not ill, and they have roughly the same risk. If both parents are bipolar, the risk for developing some psychiatric diagnosis rises very rapidly. So it's not just twice as high if one parent is ill, it's more than twice. What happens if one parent is schizophrenic, the other one is bipolar? Well, as you would probably guess, there is, in the offspring, there is a mixture of diagnosis, schizophrenia or bipolar disorder. Using family studies, Liechtenstein, so that's the same paper that I showed you earlier, paper done in Sweden, the study done in Sweden, used mathematics basically and family relationships to figure out what is the contribution of genetic and environmental factors. And they stated that there are some genetic effects that are common for the two disorders. So there are genes that increase risk for both schizophrenia and bipolar disorder, and they contribute about a third, at least a third of the genetics. There must be also some unique genetic effects, or genes that increase the risk for one or the other, but not for the other disorder. And there is the contribution of environmental factors, which they estimated at around 40% for bipolar disorder. There is another way. So this research was based on just epidemiological studies, family studies, but more recently there has been research actually using genetics, so genotyping markers across the genome, which produce something called polygenic risk scores. And I don't have time, or there is no need really on this lecture to tell you what it is, but very briefly it means that lots and lots of genetic markers across the whole genomes contribute to the risk of a disorder. So these disorders, like the common psychiatric disorders, they're not usually caused by a single mutation. Like Huntington's disease is caused by a single mutation. Schizophrenia is not caused by a single mutation. It's caused by many mutations, and maybe many common factors that are so common that we don't even call them mutations, because half of the population has this version of a gene. But if you add these across the genome, you develop something called polygenic risk scores. And this slide, which is a bit complicated, but I'll just tell you what it means. It means that these genetic factors, which are known because you can genotype them or you can sequence the genomes, they show that these genetic factors, common genetic factors, do indeed contribute to both schizophrenia and bipolar disorder. Whereas if you compare, say, bipolar disorder or schizophrenia to things like type 2 diabetes, rheumatoid arthritis, hypertension, and other medical diseases, there was no overlap. So it kind of confirms the hypothesis that these genetic factors increase risk for psychiatric disorders, but not for any other disorders. People have screened the whole genomes of many tens of thousands of patients and controls. These are the markers across the whole genome. So you see here that each chromosome and markers across the chromosome. Anyway, again, there is no time to explain how these things work, but basically these higher peaks show a high statistical confidence that something around this gene is associated with bipolar disorder. So currently, these studies have identified 30 loci that have something to do with bipolar disorder, and I have to say that almost none of them was already known previously. So it's not much to do with how our antidepressants work. So it's not to do with serotonin or dopamine, but there are other genetic factors that are increasing risk for bipolar disorder. Similar study for major depression, but here with many, many more cases. It's much easier to do studies on depression because it's such a common disorder, but actually the results are more disappointing. There are 100 loci, but you can see that the statistical significance is quite modest for such an enormous study, hundreds of thousands of cases and controls, which kind of fits with what I told you, that depression is less genetic than bipolar disorder. Now, I've mentioned several times depression and mania. So they can come in the same individual. So somebody who suffers with mania has a very high chance of developing a depressive episode. That's why it's called manic depression or bipolar. What about people who are just depressed? There are a lot more of them. Are they really suffering with a different disorder? And that's something that has bothered psychiatrists for many years. Well, there is something specific. So if you look at patients with bipolar illness, look at their relatives. Well, 8% of them have bipolar illness. You look at probants who only suffer with depression and never suffered with manic episodes. Well, only less than 1% of their relatives suffer with it. But that might just mean it's a less common disorder. This slide just shows that there are different studies pointing to the same effect, increased risk of bipolar disorder in bipolar probants, but they all have increased risk of major depression as well. What happens if you study people who have had just depression and follow them up for 50 years, as was done in this study? It shows that actually over the years, a large proportion of these patients develop some bipolar feature, not a major manic episode, but things like bipolar swings, which could be caused by antidepressants, which could be shorter, just a few days. So if you use very loose criteria, you'll find that up to 50% of bipolar patients of unipolar patients have some bipolar tendency. This is an attempt to see whether bipolar and unipolar are different using the age at onset. And bipolar patients have a mean age at onset of 33 years. Unipolar patients, the age at onset is much later. There are gender differences. I told you that bipolar patients have about 1-to-1 male-to-female ratio. Unipolar patients affects more females. Family studies confirm that bipolar 2 is more prevalent in relatives of bipolar 2 probants, and the other way around. Now, if bipolar 2 is just a milder version of bipolar 1, then you expect that bipolar 1 patients will have a higher genetic loading. Well, they don't. And you would expect that bipolar 1 patients will have a more severe course of illness, and they don't. In fact, bipolar 2 patients have a more chronic course. The lithium discontinuation study found that patients who had bipolar 1 relapsed. Well, a lot of them relapsed, but not bipolar 2 patients, and so on. So there are some differences between bipolar 1 and bipolar 2. My personal view is that bipolar 1 or manic depressive illness is an illness on its own, whereas bipolar 2 is more of a version of unipolar disease with bipolar tendencies. So it is more chronic and people suffer more with depression. Now, the more severe the mania, the less frequent the conditions. So bipolar 1 is about 1%, bipolar 2 is about 2-3%. It depends how you define bipolar 2, and maybe there are a lot more people with cyclotimic temperament, people who are just a bit more expansive, but are not really ill. And that's another slide that shows what happens if you go with great detail and try and find out bipolar tendencies. Well, you can find quite a lot if you look for features of mania, manic symptoms that lasted just a couple of days, and so on. This is a slide produced by my boss, Michael Owen, who supports the idea that all these disorders are on a continuum, including schizophrenia, autism, and even mental retardation. So they're not specific disorders. They could be caused by similar factors, and the more severe ones, like severe mutations here, they are more likely to cause more severe disruption of the brain, which presents as mental retardation, whereas the milder changes in our genes or in our brains can cause bipolar disorder, and schizophrenia is somewhere in the middle. So all these disorders have some degree of cognitive impairment, which is obviously worse in mental retardation, and almost non-existent in bipolar disorder. And of course, mood disturbance is most common in the affective disorders, in mood disorders, and not in autism and mental retardation. And there are other things like psychosocial factors. And CNVs are a class of genetic mutations, large genetic mutations. So that's probably the more realistic way of looking at these disorders. It's they're on a continuum rather than distinct. But for psychiatrists, it is important to try and keep them separated, because that affects the level of care these patients receive. It affects the communication between psychiatrists. So it's easy for me to say, I've got this patient who suffers with schizophrenia, and my colleague will understand roughly what I'm talking about. Prognosis of bipolar disorder, it's not very good. Patients are free of symptoms only 50% of the time. They suffer with mania very short time periods. Maybe 1% of their lives are spent in severe manic episodes, whereas about a third of their lives are spent in different levels of severity of depression. Well, luckily, most of it is mild and low to moderate depression, but this can be still very disruptive for your life if you're not feeling well. How do we manage mania? We give patients antipsychotic drugs, similar drugs that we use for schizophrenia. We can give them lithium, electroconvulsive treatment in the most severe cases can help as well. We give them prophylactic treatment, and there again, antipsychotic drugs like quetiapine or olanzapine, anticonvulsant drugs such as lamotrigine or valproate, or lithium. And actually lithium is still supposed to be the most effective drug, although it's almost the oldest drug used for mania. This is a set of guidelines given by the British Association for Psychopharmacology. A lot of useful guidelines, but they're probably more useful for clinicians, so I won't go through them, but you could read them later. Lithium, I keep saying, is the most specific treatment for bipolar disorder. It also potentiates the effects of antidepressants. It's got a narrow therapeutic level. It's a bit difficult to use, and unfortunately, Many of my colleagues don't use it because you need to have frequent blood tests and you need to monitor the level, but it is highly effective. And the danger is that people, if level goes above 1 millimoles per liter, patients develop toxicity, lithium toxicity, which is certainly not pleasant, but it also can be dangerous. So people are worried about the risks, and the result is that many patients are denied a very good treatment. This is a slide that's probably not of much interest for you, but maybe informative in terms of how many different drugs have been used in trials for manic depressive illness, so how acceptable they are or how efficacious they are. And on the top here are some antipsychotics that are the most kind of good profiles in terms of both being effective but also being tolerated or acceptable. So you can see our lithium here, although it's very effective, it's not liked that much due to side effects. Well, I usually ask this question if I have a live audience, but I don't have one, so I'll have to answer it myself. What is the main danger when you treat somebody, a manic depressive person, with an antidepressant? And the problem is that it can cause a manic switch. And even some specialists don't want to prescribe antidepressants to people with manic depressive illness because it might induce rapid cycling, so it might disrupt the course of illness, might make it worse, and it might cause a manic episodes. But we have to use them in many cases, and we do this by using a mood stabilizer, so lithium anticonvulsant together with the antidepressant. If we need to treat depression, it's better to use milder antidepressants such as Prozac. This stands for selective serotonin reuptake inhibitor. And patients need psychosocial support, not psychotherapy in acute manic episodes, because this is bound to fail. The patient will try and take over the treatment and advise the therapist. So, but outside of acute episodes, there is a lot that can be done. Patients are encouraged to join a self-help group. They should avoid illicit drugs, alcohol, sleep deprivation. They should try and reduce the stress in their lives. If they've got a stressful job, maybe they need to change it. Maybe they need something more stable, something that does not cause them to think, to worry about things at night. They should learn to recognize the triggers and the first signs of mania. So they need education, also awareness of medical consequences. I mentioned the weight gain and diabetes that can accompany the use of some of our drugs. Patients need to know that and avoid it, or rather avoid the consequences rather than avoid the tablets. And if you want to read more about the treatment of bipolar affective disorder, there is an excellent article which I recommend. So I'll stop sharing here. Unfortunately, in this format, we can't have questions and answer questions and answers. So I thank you for your attention and wish you all the best. Goodbye.